Okay. So, good afternoon, doctors. So, today we have Dr. Varun Agrawal from Navi Mumbai. He did MS, MCH as well as DNB, and he is practicing in Navi Mumbai. So, not wasting of time and taking. So, over to you, sir.
Hello, and thank you so much for Dr. Reddy's for giving me this opportunity today to speak on a very important topic of benign prostatic hyperplasia. Actually, it's quite important as well as extremely common topic, extremely common abnormality affecting almost all men above 40, 45 years of age. So I believe without wasting any time, I think we should start with our presentation. So what are the learning objectives today of our talk of the presentation today? First, we'll understand the prevalence, impact, and the pathophysiology of BPH. We'll see evaluation of the risk factors of BPH in men and understand the diagnosis of BPH and associated symptoms with it. Finally, we'll be familiar with the current approaches of management and describe the red flags that are necessary for referral to a urologist. First, let's see the pathophysiology of benign prostatic hyperplasia. How do you define it? It is actually a histological diagnosis, which refers to proliferation of smooth muscle and epithelial cells within the prostatic transitional zone. BPH can have different names. It's in the books as well as amongst the laymen. It is seen as it is spoken about with different terms like benign nodular hyperplasia, or it can also be called nodular adenomatous hyperplasia. Now, prevalence of BPH is known to rise with increasing age. As we can see in this diagram over here, from 31 to 40 years of age, about 8% of men are affected, whereas this number rises to 90% in the age group of 81 to 90 years. That's how common it is, especially among Asian men. Now, what an impact it has on the quality of life. Now, there was a Probe 2 survey, which was across 14 countries across Asia, Pacific, and Latin America, which showed that at least 20% patients rated most symptoms as severe. Approximately one quarter of the patients stated that many symptoms had a major impact on their quality of life. So that's how impactful this disease is. Even though it is benign, this is the impact it has had on people. The most common concerns among patients were the discomfort, disturbed or interrupted sleep, and the fear that it might just be cancer. Now, what are the manifestations? It usually in the books, in the textbooks of urology, and going according to the traditional learning, it is said that it has got a static component and a dynamic component. Now, the static component is basically direct bladder outlet obstruction from the enlarged tissue, which stops the urine from outflow. There's a dynamic component as well, which is because of the increased smooth muscle tone and the resistance within the enlarged gland. What are the symptoms? Now, when we say LUTS, what exactly do these LUTS means? They are widely divided into storage symptoms and voiding symptoms. Now, what are these storage symptoms? They can be increased daytime frequency, nocturia, that is nighttime frequency, even urgency or urinary incontinence. Now, the voiding symptoms include slow stream, splitting or splaying of the stream, as well as intermittent urinary stream. There can be hesitancy to void or straining during voiding, along with terminal dribble. There are also associated post-maturation symptoms like feeling of incomplete emptying, post-maturation dribble, etc. Now, there is a complex relationship between all these symptoms and this entire spectrum of BPH, BPE, bladder outlet obstruction. As we can see in this picture, it's quite a busy slide with multiple pie diagrams in it. All of them, as you can see, are interrelated, like BP, even OAB, that is, overactive bladder, that is also related, and all men above 40 years of age almost have this problem. What complications can we expect because of this? As we can see in this slide, there can be an acute urinary retention episode along with recurrent UTIs. Patients may develop bladder stones or even renal failure. In extremely advanced cases, there can be hematuria or a decompensated bladder as well. In these complications, usually surgical treatment is what is indicated for patients. Now, what about acute urinary retention? Let's talk about it for a while. It can be of two types. This urinary retention, it can either be precipitated or it can be a spontaneous one. When you talk about precipitated AUR, it is actually an inability to void because of some triggering agent, like it can be catheterization, anesthesia, or because of some medication. Spontaneous urinary retention is basically related to all other causes. Fewer patients with precipitated AUR need BPH related surgery. What about UTIs? They are defined as actually having two or more UTIs within 1 year or urosepsis. Mechanism of UTIs may be because of increased post-void residual urine or urethral catheterization. What about bladder stones? They are usually formed because of congestion of urine, that is again high post-void residual urine, and these men usually are treated with transurethral stone removal and medical management. Now, end-stage renal failure is generally rare in BPH patients, but some guidelines recommend case-specific serum creatinine measurement as well. Now, what do you mean by decompensated bladder? It is actually an impaired detrusor contractility, which causes irreversible loss of bladder voiding function. While it may occur in BPH patients, sometimes it is a normal consequence of aging as well. How does hematuria occur? There's upregulation of VEGF, that is vascular endothelial growth factor, and increase in the microvessel density, which may play an important role in mediating hematuria in BPH patients. After seeing the pathophysiology, let's move on to the etiological risk factors. Now, what causes this benign prostatic hyperplasia? It's again a very complex interplay between sex steroid hormones and growth factors. The hormones on your left side of the screen are basically DHT, dihydrotestosterone, DHEAS, an abnormal ratio between testosterone and DHT. And on the right side of the screen shows the growth factor, that is TGF beta, FGF2, and FGF7. An interplay between all these factors ultimately leads to enlargement of prostate. Now, there are a number of factors which influence the risk of BPH. Now, these factors may include medical conditions, genetic factors, increasing age, or dietary factors, and even physical activity and alcohol intake. Let's speak about age first. As you can see in the chart, as age advances, the chances and probability of enlargement of prostate also increases. The amount of hyperplastic tissue removed at surgery increases with increasing age. Now, what about genetic factors? Now, patients having familial BPH, they are known to have a large prostate size and they have a high lifetime risk of prostatectomy among male relatives. As you can see from the table below, all first degree male relatives have 4.4 times more chances of developing a clinical BPH. What about medical conditions? Now, there are atherosclerosis, dyslipidemia, there's diabetes, that is non-insulin dependent diabetes mellitus, even hypertension and obesity. Obesity is usually calculated by waist hip ratio, and erectile dysfunction. All these factors are associated with increased risk. Amongst the dietary factors, there is a total high energy intake and a protein intake, along with polyunsaturated fatty acids, some specific ones. These lead to an increased risk of benign prostatic hyperplasia. Now, what about physical activity? Now, it is a good thing that if you're more active because it helps to reduce the risk of symptoms. Similarly, a fun fact here that compared to no alcohol, if you take alcohol in moderation, it is in fact associated with a 35% decreased likelihood of BPH. Let's move on to the diagnosis. How do you diagnose and investigate a patient presenting with BPH? First, I would like to speak about the 4 stages that the patients present to us with. Usually in stage 1, patients would not know it. Patients would hardly have any symptoms, and even there will not be any significant obstruction. In stage 2, patient will develop symptoms. However, the obstruction will really not be that severe, and the PVR will also be less than 100. In stage 3, yes, he develops symptoms and there is significant obstruction as well. And in stage 4, he directly presents to us with complications of BPH. How do we investigate these patients? First, the medical history and physical examination. In medical history, we usually ask the duration and the severity, the associated symptoms like incontinence or blood in urine, the general condition, neurological symptoms, any bowel habits, because constipation may also be related to these symptoms, any medication that he's taking, or a family history of prostate disease. Now, when we examine him, Normally, it is to be done in a very methodical manner, starting with general examination, followed by focused or neurological examination. Even abdominal examination is important as the bladder may be palpable in these patients. Finally, going to the digital rectal examination, it is mainly to rule out prostate cancer because we may find a hard prostate or a nodule, and that may lead to diagnosis of prostate cancer. What about urine analysis? This is the next step. The urine analysis, it is mainly to identify other causes of LUTs like infection or diabetes mellitus. We do a serum creatinine and it is usually indicated in Asian population due to suspicion of high renal insufficiency rate. Avoiding diary is usually given to the patients. It's actually avoiding diary is basically a record where a patient maintains his daily input and output, and by the virtue of which the clinician gets an idea if the patient is actually consuming more water, which is causing these problems or no, and it gives us an idea about the bladder capacity of the patient. Now, next we give an international prostatic symptom score. It is called an IPSS score and a QOL score. What exactly is this? It is basically a questionnaire of 7 questions, and each question is allotted 5 points. Based on the symptoms, the clinician himself fills this questionnaire, and on the basis of which he grades the symptoms up in mild, moderate, and severe form. As you can see, if the score is 0 to 7, it's called mild symptoms. If it's 8 to 19, these are moderate symptoms, and severe is 20 to 35. What about PSA? Now, PSA is basically helps to detect prostate cancer and prostatitis. It is quite useful in men above 50 years of age with a life expectancy of more than 10 years. There should be a shared discussion between the patient and you on its pros and cons and its importance. Usually, PSA more than 4 definitely needs evaluation. A trans-abdominal ultrasound is recommended mainly to see the prostatic volume, the interprostatic extension, measurement of post-void residual volume, as well as to see the bladder stones and upper tract changes. Now, what are the additional assessments which are needed in special settings? We may direct a uroflowmetry, we may order one because it gives us a proper flow rate as to how much, it's an objective way to know the patient's symptoms. So a uroflowmetry is quite an important test in this aspect. The post-void residue is important and a transabdominal sonography. Now, what are the red flag signs? When a patient presents to a general practitioner, these are the symptoms which you should see and refer the patient instantly to a urologist. What are these symptoms? Mainly hematuria, urinary retention, bladder stones, or frequent UTIs. There can be urinary incontinence, a hard prostate, and a palpable bladder. A PSA more than 4 should definitely raise some suspicion. Persistent bothersome symptoms or poor response to medical therapy is another indication for referral to a urologist. Finally, we come to the management of BPH and male lower urinary tract symptoms. Now, how do we approach to the treatment? Like I said before, there are 4 stages. In stage 1, there is not much obstruction and the patient's symptoms are also absent. So basically, we just wait and watch and counsel the patient. In stage 2, where the symptoms appear, we usually manage the patient with medical treatment. In stage 3, various surgical options are discussed with the patient, and patient is given an option about whether he wants to go with medical treatment or surgical treatment. Finally, in stage 4, when he develops complications, surgery is the only treatment. This is a simple algorithm which clinicians can follow while treating such a patient. When patient presents to us with lower urinary tract symptoms, a thorough medical examination, history, PSA, and ultrasound is indicated. If you find some red flag signs, like on the right side of the screen, visible hematuria, elevated PSA, urinary retention, please do not hesitate in referring the patient to a urologist. Then you see the bothersomeness of the patient. If the QOL, that is quality of life score, is less than 3, you can manage with a conservative management. However, if the QOL is more than 3, then we basically do a digital rectal examination and avoiding diary. Avoiding diary, if it shows an overactive bladder, it's simple. We start with antimuscarinic agents. However, if the prostate is enlarged, quite enlarged, we give him alpha blockers or alpha reductase inhibitors. Now, these can be given in combination or as a monotherapy based on the QOL score. If the prostate is not too enlarged, it depends, and we can start phosphodiesterase 5 inhibitors if he has sexual symptoms, that is, difficulty in attaining erection, or if he does not have any sexual dysfunction, then we can give alpha antagonists as well. However, in spite of all this, If there is still worsening of symptoms or any side effects, please feel free to refer to a urologist again. Now, what are the conservative managements? Education and reassurance. It's a missed thing which mostly all doctors do not resort to these days. It's quite important where we educate and reassure the patient that it's unlikely to result in any long-term issues. We have to advise the patient about lifestyle changes like modifying the fluid intake, indulging in exercises, physical activities, reduction of coffee, tea, caffeine, and relaxed voiding, double voiding techniques. There are distraction techniques to control the irritative symptoms, and even bladder retraining is a part of it. These patients have to be periodically monitored and re-examined every 12 months. Moving on to the pharmacotherapy for BPH, what are the various kind of drugs which are available? First, alpha antagonists, alfuzosin, doxazosin, tamsulosin, terazosin, and silodosin, quite commonly available. They're available even over the counter, and they should also we should prescribe them to every patient who is actually not benefiting by lifestyle changes. Next, the 5-alpha reductase inhibitors like the dutasteride and finasteride. Now, there are combinations of these available as well. The 5-alpha reductase inhibitors plus alpha antagonists. Antimuscarinic agents mainly are recommended for those with overactive bladder like solifenacin and tolterodine. Tadalafil, that is a phosphodiesterase inhibitor, you recommend it for patients having erectile dysfunction and sexual symptoms. Finally, the other medications include antidiuretics, plant extracts, and Botox. Sorry, alpha antagonists. Now, how do they help these patients? Mechanism of action is simple. They cause blockade of alpha receptors, resulting in decreased smooth muscle tone. So that helps in easier passage of urine. There is similar efficacy among alpha blockers in improving symptoms and urinary flow rate. So all of them are almost similar. You can prescribe any of them. The common side effects associated with them are asthenia, that is feeling of tiredness, dizziness, or there can be orthostatic hypotension, that is when a patient gets up, he may have a feeling of dizziness just on getting up position. There can be intraoperative floppy iris syndrome or an abnormal ejaculation. Alfuzosin and tamsulosin, they are usually said to have better tolerability than doxazosin and terazosin. What about 5-alpha reductase inhibitors? How do they act? They mainly prevent conversion of testosterone to dihydrotestosterone, which is actually the most important hormone causing BPH. That is more effective in men with larger prostates. They mainly, as you can see in the bottom of the screen, they cause a reduced risk of AUR, that is acute urinary retention, and the need for BPH surgery and UTI with dutasteride. Now, these 5-alpha reductase inhibitors, what are the side effects? As we can see, the ear, nose, throat infections, altered libido. There can be impotence. Impotence is one of the commonest side effects with these, and these patients have to be counseled about impotence and decreased erectile function before starting these medications. Patient can have malaise, fatigue, even headaches or dizziness for that matter. Now, there were a few studies, like a combat study, regarding the combination of alpha antagonists and 5-alpha reductase inhibitors. The combat study showed that the combination therapy provided significant symptom benefit as well as Qmax improvement for tamsulosin and dutasteride. Similarly, there was a conduct study which also suggested the same. Again, combination therapy is significantly superior to both monotherapies at reducing the relative risk of BPH clinical progression. Now, what are the adverse effects because of this combination therapy? Basically, what each of the drugs had adverse effects, a combination of these two are usually found in such patients like erectile dysfunction, even retrograde ejaculation. There can also be ejaculation failure. Patients can have dizziness, loss of libido, gynecomastia, or breast tenderness as well. Now, what are these antimuscarinic agents? Like I said, they block the anticholinergic effect receptors in the bladder, resulting in a decreased contractility of detrusor muscles as well as decrease in the number of abnormal detrusor contractions. They are available in combination. Basically, like you can see, solifenacin and tamsulosin, it causes significant improvement in the symptom score and OAV symptom score as well. There is tolterodine extended release or tolterodine extended release plus tamsulosin. All these are said to be very efficacious as well as safe in BPH. Their common side effects are dry mouth, dry eyes, and constipation. So patients with OAB and no significant BOO may even be treated with antimuscarinic agents alone. What about 5-alpha reductase? Sorry, phosphodiesterase 5 inhibitors. How do they act? They are responsible for relaxation of smooth muscle cells in the bladder neck, prostate, urethra, and in lower urinary tract, as well as increased blood perfusion in these tissues. Tadalafil comes as a 5 mg tablet. It causes improvement in IPSS and International Index of Erectile Function. It is again very efficacious and safe in patients. It has a few side effects like nasal congestion, facial flushing, and headache and dyspepsia. A word of caution that these nitrates are actually not to be used in patients who are taking, these phosphodiesterase 5 inhibitors are not to be used in patients who are already taking nitrates. These other medications like plant extracts and antidiuretics. The antidiuretics mainly used are desmopressin. Desmopressin is clinically used in patients having a severe form of nocturia where they have to get up many times at night. So it can be used for treating nocturia secondary to nocturnal polyuria as well. What about plant extracts? There is again lack of established efficacy and safety. Pygium africanum is normally used. It has shown some improvement in combined outcome of urological symptoms and scores. Finally, Botox is still experimental and it is an effective alternative in BPH patients who cannot undergo surgery or who have failed medical treatment. So, a key message that I would like to give from this entire presentation, these are the key messages: that the prevalence of BPH rises markedly with increasing age. BPH is most commonly manifested as LUTS. Basic tests that a clinician should do once a patient comes to him are medical history examination, digital rectal examination, urine analysis, serum creatinine. Avoiding diary is essential. Some symptom scores, PSA, and transabdominal ultrasound. Red flags for urologist referral include urinary retention, bladder stones, UTIs, hematuria, high PSA levels, or a palpable bladder, even a hard prostate on rectal examination. These, these symptoms, if they are present, please refer the patient to a urologist as soon as possible. In the treatment, stage 1, we usually wait and watch. Stage 2 is for medical treatment. Stage 3, we discuss the options of surgery, and if the patient is comfortable, he wants to go ahead with surgery, he can, or he can continue with medical management as well. Stage 4, where the patient presents with complications, surgery is the only treatment. The various pharmacological options are available now in the market. There's alpha 1 antagonists, 5 alpha reductase inhibitors. They are combinations, antimuscarinic agents, they are combinations, phosphodiesterase 5 inhibitors, and other agents, drugs. I thank you all for a patient listening on a Sunday afternoon. And again, I'd like to thank Dr. Reddy for giving me this opportunity to speak about such an important topic. I am open and free to answer any questions. And thank you.
Yes, sir. The doctor, what is the diet to maintain BPH or avoid BPH?
So basically, diet, high energy intake, and polyunsaturated fatty acids are usually responsible. Even extremely high fatty diet usually causes BPH, like I said in my presentation. So it is quite important to maintain a balanced diet, not to have any of these in excess. And even water intake should be about 2.5 liters per day. That should be enough. You cannot have more water because the more water you have, you'll be going to the washroom more often. So everything in a balanced way is what is needed.
Okay. So second question is, sir, nocturia is related to age.
Yes, so nocturia can actually present at different ages. Even children may have it, but that is not because of prostate, that is due to some other causes. But BPH, the first symptom is usually nocturia. Patients in an extremely early stage of BPH present first with the nocturia only. So they have to be counseled at that time, and giving simple alpha blockers at that time would really suffice, and patients would really be benefited by it. So yes, nocturia has to be treated, and it is related to age as well as BPH.
Okay. Next question from Dr. Anil. What are the long-term risk of BPH?
So BPH in the long term, like I said in my presentation also, it can lead to recurrent urinary tract infections. That is mainly because of increased postcoital residue urine. There can be bladder stones. Patient may present with stones, and that may itself cause urinary retention. Or sometimes prolonged BPH can cause urinary retention as such. Patient may present to us. Patients usually such patients come in the casualty emergency at night with an obstructed bladder and obstructed outflow. And some patients on later stages may have even renal insufficiency. So these BPH symptoms, they really need to be taken care of right at the beginning, and you cannot really wait for them to progress. And because the more you wait, it can only lead to more and more problems. So yeah, there are many complications of BPH.
Okay. That's it from question. Okay. So once again, on behalf of Dr. Reddy's, we would like to thank you, Dr. Varun, as an excellent deliberation on topic of modern approach on BPH management. We also like to thank all the doctors for their taking out their valuable time and making this CME as a successful. So thank you, doctor.
Thank you so much. Thank you for inviting me, and thank you everyone for listening on again on a Sunday afternoon. Thank you so much.
Hello.
Yeah, hello.
Yeah, ma'am.
Yeah, sir. With your permission, shall we end the session?
Sure. Yeah.
Yes.
Thank you.